Hey guys, I'm so excited to tell you about the latest project from our PICU-QY work group. It's called PIFR. So what is PIFR? So PIFR stands for Pediatric Interdisciplinary Family-Centered Rounds, and it's a new basic structure, formatting, and scripting that our group has come up with as a team to see if we can improve the rounding process. PIFR can be divided into 5 main sections. Number 1, pre-rounding. Number 2, data presentation. Number 3, assessment and plan. Number 4, closing the loop. And lastly, number 5, moving on. So the first section of rounds we've termed pre-rounding. Basically, this consists of 2 major sections. The first section is essentially data collection and patient examination, and everybody's responsible for this section, all the team members. So the night nurse fills out the data sheet for the day nurse, and the night RT fills out the sheet for the day RT. Dietary, pharmacy, or residents and nurse practitioners fill out their own information. Secondly, the nurse practitioner is responsible for development of a round and plan. This plan is then shown to the attendant for approval, and then once it's approved, this plan is shared with the team members so that everybody has a general idea of the order that we're going to see their patients, and they can thus be prepared. The most essential part of this is that everybody comes to rounds prepared with their data. So this second section of round where data is being presented can get a little bit confusing as there are so many different participants involved and who should go next. So one of our nurses created this wonderful diagram about where everybody should stand. Now this is just suggested because if you stand in this particular order, then it makes the flow of information really smooth and you know the person beside you is the next person up. So if you start at the front where you see our families, their back is to the door, and next the nurses will present their data, then the respiratory therapist presents their data, then the dietitian presents her data, then our pharmacist presents their data, and then our resident comes up with our overall assessment and plan, and then our clinical team leads on CNS, they will help close the loop. Now that we're all standing in the predetermined order, let's get a little bit deeper into what actually happens. So we start off with the bedside nurse introducing the family to the team by their name. Next up is the attendant and the team member, or the team member introduces themselves and rounds, and then also asks the family if they have any concerns or goals that they want to make sure we address during rounds. The family is then given an opportunity to respond. And then next up comes the resident or nurse practitioner. Now you can see according to our diagram, they're standing across from the family so they speak directly to the family and to the attending. So they will give a one-liner so everybody is on the same page, or if it's a new patient, they can give a short HPI so everybody's also on the same page. Then the team members start presenting their data, and they present their data in this particular order only because everybody will know who goes next and it makes things run smoothly. So according to our diagram, it's the nurse, then the respiratory therapist, then our dietitian, then our pharmacy, and then our resident. We suggest maybe introducing your name and saying who you are if it's the first time you're meeting the family, but otherwise just present your data as you go along. During this last section, the residents also present labs and imaging. Hey, so guys, take a look at this video that the PICU Quality Improvement Work Group is modeling to show you what PIFR actually looks like. The only thing I want you to note is that Mallory is presenting the nursing data, so she is not standing in the spot that the nurse would typically stand, but we wanted to make sure that we showed you what to do in case the bedside nurse is not available for rounds.
Good morning, everyone. This is Hillary. This is Mark's mother. She's going to be joining us for rounds. I'm going to be filling in for Alyssa, the bedside nurse, as she's busy in another procedure. So I'll be reading the nursing information.
Hi, My name is Dr. Mahavi. This is our family-centered interdisciplinary rounds. Basically, we're going to be talking about your son today and coming up with a plan, an overall plan for today.
Okay.
Do you have any specific goals or concerns that you want to make sure we address during rounds?
Well, I think that Mark might have a UTI. I think he was a little nervous or embarrassed to mention it last night, but this morning he said something to the nurse and myself that it was burning when he was urinating, so that might be a concern.
Okay, we'll make sure we talk about it.
Oh, I'm Sarah, I'm the nurse practitioner here. We met earlier today. So thank you for that information, and we will discuss it when we get to that point. So Mark, overall, is a 15-year-old who was admitted overnight for TKA.
My name's Mallory. I'm the clinical team leader that's on today, and I'm filling in for your bedside nurse to report the nursing information for rounds. So, significant overnight events. When Mark came in, he was still having some emesis that continued up until about midnight, and then that has since resolved. We did give him potassium and phosphate replacements overnight for a potassium of 2.5 and a phosphorus of 1. 24-hour vitals since his admission. His heart rates have been 80s to 150s. This morning, he's been trending down to 90s. His blood pressures have been systolics of 90 to 130 to a diastolic of 40 to 70, MAPS 50s to 80s. The lower blood pressures were overnight when he was asleep. Respiratory rate has been 10 to 30. He has been afebrile since admission with a Tmax of 99 degrees, and his GCS is 15. He is organ oriented. Intake, he has had 4 liters in. He got 2 liters in fluid boluses in the emergency department. His maintenance fluids are currently running at 150 mLs an hour, and he's MPO. He has our 2-bag system that we use for our DKAs that's currently running D10 with normal saline with 20 of K-acetate and 20 of K-phos. And he has an insulin drip running at 0.1 units per kilo per hour. Output, he's had 2 liters in urine output. He has no Foley catheter, and his urine output has been 1.5 mLs per kilo per hour over the past 24 hours, and no bowel movements since admission. He has fluid balance 2 liters positive. He has 2 peripheral IVs, no restraints or skin concerns, and his current lab schedule is the BMP, MAG, FOS, and CBG every 4 hours and hourly glucoses. Nursing concerns, as Mother stated earlier, I have high suspicion that he may have a urinary tract infection. They obtained a UA in the emergency department but did not get a culture.
Hi, I'm Tammy. I'm from respiratory. There are no concerns as of now. Nothing to report. He's been on in there doing well.
I'm Caroline. I'm the dietitian. Mark's hemoglobin A1C on admit was 14. Once he starts eating, I'd actually recommend that the diabetes dietitian come and talk to family and Mark again about his diabetic diet. There's no other concerns at this time.
Hi, I'm Julie. I'm the pharmacist. In the ED, blood cultures were ordered and taken, but they are still sending, and there's no growth to date so far. Urine culture was not sent, and the patient is currently not on any antibiotics. Mom, it looks like at home he's on Claritin. Does he still take that, and is his dose 10 milligrams?
Yep, that's what he's doing.
Thank you.
Dr. Mojave, would you like me to go over his labs and imaging now, or kind of as they're pertinent for systems?
Just go through them in your assessment and plan.
Okay, perfect. So I'll start with my physical exam just to kind of note some pertinent things. Pertinent physical examings, normal mentation, alert and oriented times 3, no Kuznel breathing. Again, like respiratory said, he's stable on room air. Abdomen soft and untender. Cap refill is like 3+, so good perfusion throughout. With the concern that mom brought and the patient brought to us of the painful urination, we went ahead and did a chaperone exam. I found no abnormalities, but I think that when we get to FE&G, I will talk about possibly some labs. So overall,
So the third section of rounds we've termed rounds assessment and plan. This is the section that allows the nurse practitioner or the resident to shine. They start off with giving an overall assessment of what they think is going on, and then they jump into a system-based assessment and a corresponding plan. Now, when they're done with this, any outstanding questions that the family have can be answered, and then a team member, typically the attending, will then summarize the goals for the day.
so overall, my overall assessment of Mark is that he's a 15-year-old male with no type 1 diabetes who's now admitted with DKA. I strongly suspect that he has a UTI that could have triggered this, but there's also a likely component of his compliance just with his hemoglobin A1C being highly elevated on admission, and this is his 3rd admission this year for DKA. So respiratory again, room air, no concerns there. cardiovascular. He was tachycardic on admission. Since we've rehydrated him with a couple liters, his tachycardia has kind of improved, or it has improved. FENGI, his labs this morning showed that his gap had closed and his CO2 had improved to 17, so I went ahead and transitioned him this morning with his home Lantus with carb counting of 1 to 15 ratio per his home regimen. His hypokalemia has improved. It was 2.9, it's now 3.5 this morning. Hyponatremia, he was 131, he's now 135, and hypophosphatemia has also improved. He was 2.2 and he's now 3 this morning. Endocrine and diabetic dietitian have already been consulted, and both have seen him this morning, so we'll follow up on their notes and recommendations. ID-wise, again, I agree with the nurse and with mom's concerns about this possible UTI, so I already mentioned to them about grabbing a urine culture so that we can follow that. And then I'd also like to start him on Rocephin empirically while we follow the cultures, just 50 mg per kg IV daily, and then once he's tolerating PO, we can transition up to something oral at that time. And then disposition, I think with us transitioning him, we can send him to the floor today.
So the fourth section of rounds we've turned closing the loop. This is mainly for housekeeping, and we thought that the family did not necessarily need to be around for this section. So after we've said goodbye to the family, we've closed the door, it's time for us to close the loop. So we start off with our medication review, and this is only if they have not been done already. So talking about changing IV to PO, appropriate medication dosing and levels, all home medications ordered. Number 2, it gives the resident nurse practitioner a chance to read back the orders. Then we update our problem list. Then we jump into patient safety and hack data. Now, this information is the responsibility of the clinical nurse specialist or clinical team lead, who will be listening during rounds and will update us at the end only if there's information that they've seen that we're missing.
An excellent plan, Sarah. The only thing I want to add is Julie had mentioned the Claritin.
Yes.
We should probably start that. Okay. So, do you have any questions? I know we quickly went through our rounds. Any questions based on anything we said so far?
No, I don't think so. I think we covered it all.
Okay, perfect. So, in summary, our goals for your son today include, number 1, we're going to go ahead and treat him for his urinary tract infection, or empirically treat him until we get those cultures back. He's already been transitioned, so that's good. And then hopefully send him to the floor this afternoon if he's tolerating his diet. Okay. Okay.
Great, thank you.
Thank you very much.
All right, thanks.
All right, guys. So let's do the last section of rounds. Let's do our order read back and our med review.
Okay. So order read-back, orders to transition have already been entered this morning prior to rounds. The only order we've added is the Rocephin 50 mg per kg daily, and then his home Claritin 10 milligrams daily. Were there any other med changes?
No, none at this time. We'll just watch that culture and make any antibiotic adjustments based on that.
And I don't have any safety concerns other than the VTE screening still needs to be done.
Okay, I'll look into that. I will score him, but if we get him up and ambulating, I don't think it'll be an issue.
Okay. And Mallory, make sure you write those goals on his sheet so that when Alyssa comes back, she can transcribe them to the board.
Okay.
All right? Sounds good?
Thanks.
So the last section of rounds we've termed moving on. Basically, this provides an opportunity for or gives a slot for the nurse to write on the board the goals of the day that we've already determined, and also provides time for us to either do some learning points or just simply move on to our next patient. I'm sure you have a lot more, but we can start off with these. So number 1, what do we do on weekends when pharm and dietary are not present? So we recommend that the resident be responsible for presenting this data and in the same order so everybody gets used to this order. Number 2, what to do if bedside nurse is not available. So it is the expectation that the data sheet is filled out by nursing, typically the night nurse. If the bedside nurse is busy, please let someone know and we'll be more than willing to help you get prepared for rounds. Anyone can read off the iron script, but for now we're trying to make sure the CTL will be preferable if they are available. Number 3, what do we do if the unit is busy and a team feels they can't PIFR? Just go with the flow, do your best, and ask the question, should we or should we not PIFR today? Number 4, what if team members don't want to PIFR? Just go with the flow. And lastly, I am an RT. Do I have to PIFR for a patient that has no respiratory issues? No, you do not. But if you're free, we always love if you join us. Thank you so much, guys, for watching this video. I know it's a whole new way of looking at rounds. All that I ask is that give it a shot, and I would love to hear feedback about what you like about it, what you don't like, about how we can make the process even better. And again, above all, thank you for giving it a shot.